All right. So thank you all for coming together to talk about mobile health units for FQHC health centers. We do have a couple of guests and we have some other participants joining us who are going to listen in who aren't necessarily from FQHCs, but we welcome them and are excited to hear about people's experience. Our agenda today is pretty short. We have about 2 hours. We're going to have some guest speakers, Rebecca Stauffer, Maria Ferris, and Michaela O'Brien. And then we're going to have some open discussion and share our experiences. We have quite a few health centers on the line, I believe, who have been doing mobile health programs or who recently started mobile health programs who would be, I'm hoping, willing to share their experiences. And you will have the opportunity for questions, both from your peers and from our experts. And then, of course, I'm going to ask you to fill out evaluations because we wouldn't be the PCA if we weren't asking you to fill out an evaluation. All right, so if everyone could go ahead and put their name, organization, and title in the chat so we can share who all is here. I'll give you all a minute to do that. And I actually can't see the chat at the moment. Let's see if I can make it pop up here. There we go. Okay, thank you. Hi, Brianna. It looks like you're joining us from your car. Be careful, please. All right. So we're going to start off this morning with a quick survey. If you, on your device or on your phone, could go to www.menti.com and enter the code 79937012, or there's a QR code on your screen that you can use with your phone. We're going to take a quick minute and do pretty basic survey. Some of these questions you may have already answered. Let's see if I can pull up the survey. There we go. So we just have a basic, do you have a mobile health unit? Just like, let's see, make sure that gets up there. Okay. I'll give you all a minute just to answer that real quick. Looks like most of us on the line have a unit. Thank you, Rebecca. All right, so our next question is how many units do you have? If you only have one, 1 to 2, 2 to 3, or you've got maybe more than three. Oh, we do. We have someone who has more than three. Okay. Does your clinic also offer street-based based services. So those would be services you provide to patients that either take place on the street or that take place in a parking lot or without the support of a mobile health unit, without like a van or any other sort of unit. Okay, and then which days of the week and hours during those days is your mobile health unit operating? Just go ahead and type those days, hours in. Specific events. Okay. Okay. And then how many different locations do you visit if you're only visiting one or if you're visiting multiple? And I think we're just asking for one, many, 12, 3, that kind of thing. Okay. And then, oh, there we go. What services does your mobile health unit offer? If your services aren't listed on the list, go ahead and hit other, and then on the next slide, we'll ask you to fill that in. Oh, good. We do have some behavioral health. Excellent. Okay. Okay. And then if you answered other, if you could type that in here, I'll give you just a minute to do that. All right. And then the name of the EHR that your mobile unit uses, or if it does not, if you are doing things by hand, epic, epic, epic. Just gonna have a whole screen of epic on here. And then our last questions, are you asking patients to utilize things like tablets or computers on your mobile unit for any sort of registration or follow-up? Um, or you have some sort of app on the phone? Okay, excellent. All right. iPad. Okay. All right, so that is our last question. I'm going to stop sharing here. I want to introduce the first of our speakers today. Rebecca Stoffer is from Cohn Reznik. She is going to talk to us today about the aspects of mobile health unit program. And there you go, Rebecca. Thank you so much. And I will hand it over to you.
Thank you. Thank you so much, Sonia, and thank you so much to the Oregon PCA for the invitation to present to all of you today about mobile health. You'll find out I am very passionate about mobile health, as I think we all are. And thank you so much for all of that survey data. That was really informative, I think, for both my presentation to also know who's in the room. They use that term virtually, as well as for my co-presenters from Mission Mobile Medical. And we'll be able to I'm just very excited for the FAQ that we'll have later and be able to really answer some of your targeted questions. So let's just dive right in. As a reminder, this presentation is just for educational purposes only. And what I'm hoping that you'll be able to take away with from my presentation today is for you to be able to identify the planning components for either building or growing your mobile health program. You all have mobile programs, but you all do it in sort of different ways. And so hopefully today you'll see and see some ideas, get some ideas for how to expand your mobile program and do something new and different. Also, I will be describing, and hopefully you'll take away from this operational, clinical, and workforce best practices for operating your mobile health clinic, and then an ability to evaluate key financial elements so you can build a financial sustainability business. So to do that, here's our agenda. Just going to go through this really quickly with some introductions. We'll just jump into a quick overview of strategic business plans, and then I'll touch on needs and market assessments, building a mobile health program. Mobile health program sustainability, I'm just going to touch on with the Mobile Healthcare Act. I'm going to talk about that, and then talk about developing an action plan before I hand it over to my co-presenters. So who am I? My name is Rebecca Stoffer. I joined Cohn Reznik in January 2022. I come from an FQHC. I ran a New York City-based FQHC that served individuals experiencing homelessness, and that's where I oversaw the entire FQHC, both strategic planning, operations, finance, as well as the mobile health program. And I really worked hard to try and integrate the mobile program into the 4 brick and mortar sites that the social service agency had. It also went shelters, which was out of scope. But I also have a background in public health, program operations, grant management, and administration. I'm very passionate about mobile health programs, and I really enjoy speaking about it and really helping health centers develop sustainability and successful mobile programs so that you're able to use your mobile programs to enhance your FQHC and be able to establish and operate your mobile health program, as well as integrate it back into your brick and mortar FQHC program so that you are creating both efficient and effective services for your patients, both in your clinics and also in your full program sites as well. Now, Cohn Reznik, not sure if you've heard of us, we're a leading national accounting, tax, and consulting firm. And you may be familiar with our audit and financial services, but we also have a specialized community health practice that's been supporting FQHCs and partnering with NAC and PCAs all across the country for over 30 years. We work with FQHCs all across the country, and we bring our expertise in operations, federal regulatory reports and compliance, revenue cycle, financial and strategic business planning to the whole FQHC. And so with all of these services, we are able to help FQHCs to strategize the use of your mobile services as a solution and complement to your FQHC. So we are just so excited to be able to present to all of you from the Oregon PCA today. So I'm going to jump right into a strategic business plan. So there's two key outcomes for planning a mobile program. One is how do you design and launch your mobile program? And two is how do you integrate your mobile program into the rest of your FQHC so your mobile program is an additive complement to what your FQHC already does, or is a stepping stone to what you want your FQHC to really grow into. Maybe it's a new patient population, maybe it's a new service area or new services. So what you need to do to be able to do that is you need to take the time to create the right strategy. And as we all are here, we all have a passion and are mission driven to deliver that solution to help your patients, whether they're in your brick and mortar or on your mobile unit. But how often do we really take the time to strategically plan? And so when it comes to your service delivery program, your planning is really key to ensuring that you're able to meet your patients' needs. Keep your staff satisfied. Without your staff, you're not going to be able to deliver your services, and also contain costs. I'm sure you've got your finance team on there is like, well, how much is this going to cost me, and why do I need to keep this mobile program? You all, as the mobile program leaders, you are the individuals that are going to constantly need to be justifying and advocating to your finance team. We need to keep mobile for all of these reasons. To do that, you want to make sure you're doing it from a really key strategic foundation. So that strategic planning is really key and critical when it comes to your mobile service programs because of how it's an additive component for your services that you're developing for your mobile program and off your mobile program and across your FQHC. So what is a key strategic business plan? So just in case you may not know what this is, I'm just going to do a quick 30-second primer on strategic business planning. They blend, so a strategic business plan, I'm sure you're all aware of, a strategic plan, I'm sure you're all aware because you have to do it, but a strategic business plan blends aspects of your strategic plan with elements of your business plan. And this, like I said, is going to be a really high level. And you want to think about developing your strategic business plan for your mobile services. And so thinking about what are the strategic goals that you want to achieve with your mobile program? What are the plans for what actions you'll take and by whom to achieve those goals in your strategy? Details as to how those actions will be taken in your approach and tactics. Now, with a business plan, you build on top of that strategic plan by grounding the goals of your strategic plan, first with your market assessment, which I'll talk through, to identify the organization's opportunities. Then details for how your goals will be achieved, a staffing plan, which I'll talk through, and a financial component, which I'll touch on. And then your business plan will guide the build of your vehicle, which is, of course, a capital asset with depreciation costs that's going to sit on your financial books for a number of years. So before you as a health center want to put a mobile unit on the road, or before you want to think about enhancing your mobile unit, the key to developing a successful mobile health unit is to understand the environmental factors, your population's needs for services, and the staff structure that your organization can develop to deliver your mobile health services. Each mobile program is unique and needs to be customized to the environment, the patient population, and the services that you are delivering. So therefore, you as a health center want to be able to ensure that you're building a successful and sustainable mobile program. And so you first want to assess the opportunities that align with your organization's service areas, your services that you can deliver, and your patient population's needs to ensure that you are achieving a equitable and accessible care program as the basis for your mobile program. So to start your mobile program planning, there are three key areas to consider: your patients, your services, and the environment. And the three most important questions here are: who are you serving, what do they need, and where is it needed? And for your mobile health units, that's focused on, if you have them on special populations, you may be also focusing on a migrant population, you may be focused on a public housing population, or you may be focused on a general population where you are going to serve a really, maybe you have a hotspot. I saw someone in the survey doing diabetes care. You may have a hotspot in your service area that really needs a lot of focus on diabetes. Knowing all of that information is really helpful to then be able to plan what services you're going to offer on your van and how you're going to do that. Now, also, as I said, each mobile program is unique and you want to customize it to your environment. And you want to make sure that you are not only serving the patients that have those needs, but where are they located? And then what is the environment in which you're going to take your mobile unit out into? If you're serving migrants, how far are you going if you're going from farm to farm to farm? Or are you setting up a mobile unit in one area and all of your patients are coming to you? These are really key questions you want to be able to outline and answer before as part of your planning. So the needs of your target population, community you're looking to serve, can be obtained through your focused, customized, and unique needs and market assessments that just is focused on just what you want to do with your mobile program. Now, your FQHC does a needs assessment every 3 years. It's a requirement. You may also do it more often if you're doing a grant if you're doing a new grant, or if you're doing your service area competition. But this market and needs assessment I'm talking about you really want it to be focused on what is the goal of what you're doing with your mobile program. So it needs to be thoughtful and purposeful process that's providing you information about the demographic and health status of this population that you want to serve in that specific area with unique characteristics of those residents. And again, also you want to look at any perceived barriers to care, utilizing health, social, and demographic data. So if you have and know what those barriers to care are, you will be able to then address them with your mobile. So a needs assessment can demonstrate also growth trends of the patient population so that your health center can plan in advance for trending changes in the patient population. So does your needs assessment show that your demographic is aging, or are they getting younger and you need to either, if it's aging, or do you need to find and bring in geriatric care if your patient population is getting younger? Do you need to start bringing in pediatric care, young adult care, adolescent care, that kind of thing? So that's where a needs assessment can really start to help you plan in the future what kind of services you think you'll be needing to provide both at your health center, but also how your mobile program can respond to those needs as well. Your needs assessment can also ascertain the unmet need in your service area and help you, or also a target population, and that can also help your mobile program plan to what kind of services do you want to deliver to meet that unmet need. Now, market assessment is an additional layer to showcase who are the market players in your service area or who you're currently serving, as well as who you need to serve. And this can look at help you demonstrate either potential competition or partners to aid in developing your strategic business plan. There's lots of different tools out there, data sources, and approaches for performing both your needs and market assessments. So to close out this part of the presentation, just want to go through this quick checklist for your market assessment and needs assessment. So your assessments will look and address your general demographics of your patient population. You'll look at the health status, chronic disease mortality rates. There's lots of data sources out there that can be used. You can first start with your UDS and your EHR data. There's also a lot of publicly available sources. Your PCA might actually have some needs assessment data you can use, but you can also look at your census data, health outcome data from your local health department, as well as look at community needs assessments from hospitals and things like that. HRSA has some great tools that you can use with their new mapper tool to look at your professional shortage areas. Lastly, you can also go to your community. Do community needs and do some feedback. You can do some key informant interviews, patient surveys, community surveys, town hall meetings, focus groups. That way you're really in the community and talking to them to be able to understand what those hyper-local needs are, to be specific to the communities, your communities and your populations. Okay, so now you know what are the needs in your community and who you want to serve. So how do you start building your program? And so with that, you want to think about how you build your program across these domains. So thinking about, as I just sort of transitioned from that community health needs assessment, who are the community support and partnerships in your community that will help you? Building those relationships will be vital to the success of your mobile program, so that you're able to then use those community partners to develop and launch your mobile program, help introduce you into a new area, introduce your van to new patients, and help build that trust in the community. For operational protocols, you want to create a specific staffing model for your mobile program, which I'll go through in just a second on my next slide. Your mobile staffing plan will require specific workflows, policies, procedures, key KPIs, data management systems for delivering and monitoring your clinical services, as well as making sure that you're meeting any business benchmarks that you want to set for your mobile program. And then you also want to plan for how the patients that you will see on your mobile unit will be seen back in your brick and mortar site. So if you have Epic on your van, hopefully you have Epic back at your FQHC, and you can create some workflows with referrals for patients that you see on your van. Maybe they need some follow-up care or some test results back at your brick and mortar. Now, funding for your mobile program is really critical to launching and operating your mobile service van. And so part of your mobile program is going to be looking at what costs will be incurred, what revenue is needed, and from what sources are you going to be generating both your revenue as well as your costs, other than patient revenue. How will your mobile programs fit into your overall FQHC budget, and how are you going to be handling that in the financial reports to your budget and terms? And lastly, the licensing and regulatory components of launching a new van or new services really is critical to think about. How are you reporting it to HRSA, but also what kind of agreements are you putting into place for with those partners, as well as what are some state and federal regulations that you need to put into place regarding the billable space on your van, as well as what kind of van you're building, if it's at a certain size. I'm sure Mobile will talk about this or can answer these questions when it comes to making sure that you're meeting federal Department of Transportation regulatory licensures as well. Okay, staffing. Now, staffing plan for your mobile service has many of the same components that you would have for your brick and mortar, but as you all know, since you have mobile services, it's different. There's less space. You can't have everyone around. And so you want to be really thoughtful about what a clinical staffing plan and a support staffing plan is on your van. Who's going to be, depending on the services you provide, who's going to be the clinician on the van? What kind of support do they need on that van in terms of clinical support as well as operational support? Who's going to be doing the pre-visit check, patient registration, scheduling, as well as that? Will you be doing any of that on the van, or will that be done by your brick and mortar for your patients who are coming on the van? All of this kind of takes planning, and you want to make sure that you're working out all of these kinks about who's going to be doing what these operational processes are for as you build your van. Now, the other key component about a mobile service van is this non-clinical side, to the right side of your screen. As you see, this is really important because you need to make sure that your van is maintained, your vehicle is maintained. So making sure that you have the right staff who is if you need a specially licensed driver, but someone who's skilled and familiar with taking care of that vehicle. But you also want to make sure you've got your programmatic, operational, and administrative leadership who is going to keep your program running, help you as the mobile health program lead, or maybe the staff working on the van, provide that guidance around strategic planning, problem solving, community engagement, outreach, that kind of aspect when it comes to surrounding and supporting your entire. So now that you've got an idea of your services, you've got an idea of your staff, a really important component, of course, of developing and creating a diligent financial plan. This includes questions for both how your program will bring in revenue and what will it cost to run your program. And so this aspect of mobile programs is going to be really important to be able to outline and present to your leadership, present to your finance team, but also to your board's going to want to know. So for your revenue, who will pay for these services? What is the payer mix? How will you be paid for these services, and how much will the program earn? So you can offset any of the expenses. How much will this program cost you to run? What are the costs? What is the operating margin? What are the costs per visit? And again, how does this financial model for your mobile unit fit into and affect your entire FQHC financial budget and financial goals? This is an area where integrating your mobile program into an FQHC is really crucial as part of that strategic business planning activities that I presented earlier. So now you have your financial plan, you have your program design, and a staffing plan, so you can start putting everything together for those components of a strategic business plan. So all of that planning has led you to then planning what kind of vehicle you want to build. Once you know all of these answers, or what your staffing is, and your model, and your financing, you'll then be able to go to bid out who's going to be the vendor for you to build this van, or how to then be able to go procure this van. Your strategic business plan will help you determine your procurement process that you're required to go through for selecting your vendor and your contract management, so you can make sure that this part of this capital asset that you're going to be bring into your FQHC is compliant with your policies and procedures for FIRSA and for your FQHC for select. So sustainability, as we've just mentioned, is a really key component, and I'm going to leave most of this part of the presentation to my co-presenters from Mission Mobile. But one key aspect I do want to talk about is the Mobile Healthcare Act, because it can be a sustainable source of funding through new access points that have now been released. I don't know if any of you have heard of the new Mobile Act. It's not kind of new anymore, but is now in effect, which is really exciting. So MOBILE stands for the Maximizing Outcomes Through Better Investments in Life-Saving Equipment for Healthcare Act. And it allows health centers to utilize federal funding through new Access Points grant program to establish new mobile healthcare delivery sites. Now, this is effective as of January 1, 2024. So this means that the current NAP funding opportunity that was released a couple of weeks ago is now able to be used for supporting mobile health sites. Now, NAPs have always been able, you've always been able to use NAPs for mobile sites, but what this means now is that if you are a FQHC with existing brick and mortar sites, you can now for the first time use a NAP just for your mobile unit, which is super exciting. This is just a quick screenshot of what the Act says. And this is what the before time was like, and this is now what after time is like. And so if you, like I said, are an existing 330 grant, you can use these new access points, oops, I went too fast, to just propose a mobile only site. So that means that when you put your NAP in, you can use all this $650,000 for your NAP, for your mobile unit, but your mobile unit has to be full-time and has to offer at least primary care. Now, if you're a lookalike, you still, and you can want to apply for the new Access Point grant, you still have to propose a brick and mortar site, but you can also add in that group as well. Okay, so to close out this aspect of my presentation, I just want to provide some experiences from the field, from when I was running my mobile programs. And that the key is really to build trust with your patient population by creating consistent schedules that you are providing when you're on site, and what you're providing your services, and you're going to be there all the time to build that trust. Having experienced, flexible, compassionate, and trained staff and providers is going to be really key for building that trust, as well as finding those partners to help you build that trust and enter those communities. Managing and planning for costs is really key. So costs for parking, you want to make sure to plan and budget for costs for parking and maintaining your vehicle, any downtime costs, maintenance and vendor management costs as well. And last but not least, making sure you have safety plans for emergencies on the van, safety plans and emergency plans for any emergencies outside of the vehicle, such as weather or road. And that also means thinking about what are your mitigation plans for downtime. So what are some plan B plans, whether you have inclement weather, a vehicle issue, or any staff related or service related hiccups. You want to make sure you have your plan B so you can still continue to build that trust with the community and with your patients, as well as be able to be consistent with the services you provide. So to close this out, when you're launching new programs or expanding your new programs, I'm a project manager. I love lists, and so I want to leave you with a project management list to start thinking about planning your to-dos. So analyzing the alignment of a mobile program plan with your organization's services, sites, and goals. Determine the service line you're going to provide on your mobile unit, which is also your staffing model and your financial plan. And then draft and launch an internal and external communication plan for how you're going to bring these mobile services to market. Conduct your needs and market assessments to help you with that plan, so you're understanding and aligning your target community's needs for services with what you will be able to do. And then, of course, engaging with the communities through a variety of methods we already talked about to ensure and align that the needs that you think your community has that you're able to offer truly are those needs. That also, again, helps you build the trust with that patient population. And then create an implementation plan and identify a project manager and leader who's going to help you really bring your program to fruition and launch it. And lastly, This is my contact information. I'm so excited to stay on for listen to all your questions and have more of a fruitful conversation. But I'm also here for guidance and assistance and to help you brainstorm any ideas should you have them. So thank you. Sonia, no, we can't hear you.
Let's try that again. How about
Thank
that?
you.
It helps if the microphone is next to your mouth. As Rebecca said, she'll be on for questions later. Our next presenters are Michaela O'Brien and Maria Ferris from the Mission Mobile Health Medical. Wow, let's try that again. Mission Mobile Medical. So you have your slides up. Excellent. Go ahead, Michaela.
Thank you so much. And Rebecca, thank you for starting the presentation off with talking really about the planning. If there's one thing that I learned in my time with running my own mobile clinic program is how important having those plans in place are, because it really helps with optimizing the work that can be done in a mobile clinic space. So that was really great to have you walk through those different considerations to have. So really, I'm going to shift into talking about program sustainability with an emphasis on the financial piece of it, because we want to be aware of what it takes to run these mobile clinic programs, which there's a cost associated with that, and how to really optimize the work you're doing in this space. A little bit about Mission Mobile Medical. We are a mobile healthcare company and we work throughout the United States. And we have been around for a little over 4 years, started right when the pandemic was announced. So that was kind of a curveball that we weren't anticipating in this new endeavor. But it actually opened up a field of organizations that were wanting to expand into the mobile healthcare space. So we've gotten to learn a lot from our clients and partners who are doing the work out in the field, myself included, as a past client of Mission Mobile Medical, got to share what that world is like, because the mobile healthcare space is really unique. We're seeing people that we wouldn't traditionally have come through the front doors of our brick and mortar sites. They're people that for years maybe haven't had access to high quality, equitable care. And so that's something that really positions the mobile clinics in a great light of being able to bridge that gap that we're seeing in the healthcare industry right now. And so, as I mentioned, I have a background in running a mobile clinic program, specifically in the county government space. So I was with the local health department here in North Carolina, where we were fortunate to receive some funding through ARPA dollars to support our mobile clinic program. And this was a really pivotal time for our health department to finally have a way to get to our county residents that were in the most rural parts, that they weren't able to get on a bus line or go to a clinic in their neighborhood. So we really brought care to them and met them where they are. And that really ignited a passion for this space, seeing the impact that we had in those communities who weren't given the time of day or access to care in alternative hours really led me to want to come here today to help other people plan their programs, optimize it, be able to build a sustainable program that they're able to run for years to come. So in today's presentation, I'm going to cover financial sustainability, specifically through a financial model we've developed with federally qualified health centers in mind to make it very cohesive and user-friendly. Of you can just plug the data in and determine how to best optimize your program based on a few different factors. I'm going to talk a little bit about program development, when you're selecting your clinic, some layout considerations, and how to really optimize a small real estate space, and then the clinic service and maintenance to ensure uptime of your program. So financial sustainability, this is probably one of the biggest things that you need to consider when you're building your mobile clinic program. And we've broken this up into a 7-step model that walks through the considerations you should take when you're building out your plan for your mobile healthcare program. And so step one is planning. And this is what Rebecca was talking about in her presentation, where you're going to take the time to understand what are your community needs? What's the market research telling you? Who needs the most care? Is it expansion of your services to a population you haven't traditionally served but would like to? So really taking the time to build the components and the building blocks that's going to make you successful and guide how you build your financial sustainability. So just to touch on some of those key, um, some of the key pieces that Rebecca touched on, we want to understand the area, the logistics, the provision of services. What are the outcomes that we're looking for? So we want a mix of our quantitative and qualitative data. And this is not only to influence the program itself, but also measuring impact of that program. What was the success of deploying a mobile clinic program? Some examples of that is patient satisfaction and experience. And then others where it's more quantitative is actually looking into maybe it's number of vaccines you administered, number of appointments, things like that. And this is going to be really important to capture in your program for sustainability efforts and future funding opportunities. What is your evaluation plan? So this feeds into your effect theory as well, and really understanding what is going really well with our program. How do we know that we're making a positive impact, and where is there room for improvement? So getting into the habit of constantly evaluating the work you're doing, and then being able to pivot and implement changes to make that program that much stronger. Your sustainability plan, and we'll dive deeper into that piece in the next few slides. And then what's your timeline? So when you're launching, are you doing a soft launch to build up buy-in in the community, or are you doing a hard launch where right from the start you're operating 5 days a week? When are you going to evaluate? Would you do special events, community requests, things like that? So really developing the plan of how you plan to implement the program is going to be really important. But I want to look at kind of steps 2 through 7 of our model. And step 2 is really focused on productivity. So here on the left-hand side of the slide, everything that's highlighted yellow are data points that we capture from an organization as we work through this model. And this is really to understand what potential productivity you can have in the mobile clinic space. And so we look at how many providers you're going to have on your clinic. We want to understand what is the provider visit length. And this is different than the total time that a patient would be on your clinic. So once they get there for registration, and then maybe they're doing some initial intake, and then the provider sees them, and then maybe they have lab work. That's much longer than 20 minutes, 30 minutes. So we really want to focus on that provider visit length, because you're going to have support staff to help with the other components. How many days are you planning to operate your clinic? So that's really important. The number of visits that you intend to see. And then what does that look like on a year timeline? So the capacity that you could create. And we really want to put this in a realistic spotlight. So understanding that in your first year of implementing a program, you likely aren't going to be at 80 or 90% efficiency right out of the gates. It's going to take a little bit of time to build up your patient volume and continuum of people coming back for those follow-up appointments and building your patient census. And so this is what this model really captures, is it's a realistic forecast of what your program could create for productivity. And so that's what we're just showcasing here in this bottom slide, is looking at year 1, year 2, year 3, and building up the number of visits that you could see on your clinic. And then labor cost. So I really like that in Rebecca's slide, she shared you have your medical staff, and then you have your mobile clinic, more of the equipment maintenance staff. And it's really important to identify who those people are going to be for your mobile clinic. And the space is very limited. So you'll see, and most of you who have clinics probably know, it's important to cross-train your staff members and have them be able to kind of flex and do a little bit of everything because you don't have a lot of room for a full-fledged team of 10 plus people like you would at your brick and mortar. So when you're doing your staff profile, we always recommend trying to identify what those roles look like. This is an example for a primary care medical clinic. So you want to have a provider, a medical assistant, or a nurse, a community health worker for resource navigation and connection to social services, and then your operator. You want to take into account what the wages are going to be, as well as how frequently are they working on the program. So what is their FTE? Is a provider there maybe 2 days a week, and then the rest is all using telehealth, or it's just screenings where a nurse could lead? So thinking about that and then adding in your labor overhead. So our general rule of thumb is it's between 20 to 25%. This can fluctuate depending on your organization, but just take that into account when you're starting to build out what that labor cost profile is going to be. One thing I always really like to emphasize when you're looking at your staffing model is the operator. And so your operator is someone that can really have a dual role. It's important to have them understand the maintenance and being able to drive the clinic to and from the site, but then utilizing them while they're on site at the clinic. Can they help with getting people registered? Can they greet people? Depending on your program, we've seen our opioid treatment program, sometimes they're a dual role of their security and the driver. So there's a lot of unique ways that you can make this a dual role, so you're really maximizing the time and use of their time as well when they're with the clinic. So then we want to talk about what are your expenses, so those direct costs of being able to provide services to your patients. So the first piece is when you have a program and you're getting ready to start a program, there's some initial startup costs. So different things like getting credentialed, licensure, expansion of your insurance coverage, things like that, that are going to only happen in that first year where you would have to front some money for that. We want to take into account medical supplies, and we recommend doing an average per visit calculation, just so that you budget for the appropriate amount of money to cover the cost of the supplies. In the medical space, we found that anywhere from like $6 to $10 is a pretty good average, depending on what the breadth of services are that you're offering. Certifications, so if there's any special training or things like that, so if you need Narcan administration, CPR, anything like that, you want to make sure you're accounting for that and understand who needs to have those certifications prior to implementing your program, and also understand what the renewal time frame is. Is it annually, biannual, those types of considerations. IT is really important. So your EHR, IT capabilities, and Wi-Fi capabilities are going to be one of the things you want to consider of, are you doing satellite? Are you doing cellular connection with a SIM card in your router? EHR, are you adopting that from your brick and mortar, which we recommend? That makes for the path of least resistance and access to the patient's full medical history. And then telehealth. If you're providing telehealth services, do you have the capabilities and a camera or tablet set up in the clinic that can connect back to the home base where the provider is to connect to the patient? The other piece with IT is considering interpreters. So if you don't have bilingual staff that will be on the clinic, having a backup of an interpreter, whether that's through Language Line or one of the other popular platforms, just to ensure that you're able to provide services to anyone who comes into your clinic. Storage and fuel, it's an important one, and there are costs that are associated with both of those things typically. So storage is your overnight parking. Are you keeping it in a gated area? Is it in an actual storage unit with a locking gate and you pay a monthly fee? Those types of things you want to factor for. Fuel, we gave kind of just a example of how you can look at it, figure out what the average price per gallon is for fuel in your state, how many miles per day do you anticipate driving, and then how many clinical days per year do you anticipate operating? And that's going to give you a good estimate of what you can anticipate spending on fuel for your mobile clinic. And then fixed expenses. So these are things that are likely going to occur each year. So think of your auto insurance, your marketing and outreach efforts, any service contracts. So things like managing your tanks, sanitation of the clinic, any cleaning, sharps containers, those types of things. And then a contingency budget. And then the last piece, which is really important, is your program coordination and program planning. And so who is taking ownership and being your program champion to ensure that all of these things are being considered, and managing the budget and understanding where you're at to help influence and strategize how to best optimize what you're working with. So now that we've gotten through our expenses, we are going to shift and look at revenue. And so the first revenue generator is going to be your payer mix. And so this is really looking at our service income. And on the left-hand side here, there's this model that talks through kind of 4 categories to consider that's going to influence your payer mix. And this is really what's going to be helpful and critical to building that sustainability in your program. So looking at your reimbursement blended rate, so this breaks into how many recipients are Medicaid, Medicare, private insurance, and then that feeds into an average blended rate that's going to help you project what your revenue could be for the course of a year, 2 years, 3 years, 5 years. Managed care, does your organization currently have enrollment in the managed care program? Is it something you're working towards? So we are able to factor that in, as well as a revenue source. Your number of visits is going to help us forecast what that potential revenue could be for your program, because revenue is dependent on patients seen. So what's realistic to where you're going to be going, the population you're serving, and what does that look like? And then your percent of allowance for uninsured visits. So I know in a federally qualified health center space, there's a sliding fee scale. But I also know there's a few people on the call that are not an FQ. So, looking at, is this a service offered at no cost? Are you going to do a sliding fee scale? Just have an idea of kind of what percent of these people you think you will be able to serve and how you're going to offset some of that cost. Because the last thing we want is to deny someone services. We want to make sure that they're able to get care on the clinic. So just having that planned in is really important. And then the return on investment, this is probably one of my favorite components of the financial model that we've built. And that's really because we're looking at, when you go and seek additional funding to supplement your program, we immediately want to find a grant or someone who can provide, a few $100,000. But really, we like to shift that mindset and perspective a little bit to look and see what impact the program is having on multiple organizations and partners. And that's really where we get into the ROI model, so the return on investment model. And it's really going and asking 10 people to contribute $30,000 to equate to your $300,000 need, and present it in the light of, by them making that investment, here's the return or the results that they could anticipate receiving. So for example, with a school district, by providing care to school-age kiddos of immunizations, sports physicals, regular primary care, sick visits, things like that, that return is the reduced absenteeism. No one's being excluded because they're not compliant with immunization requirements. Higher graduation rates. They're actually in school, getting to complete school and graduate on time. They're not falling behind due to being out of school. Looking at your municipalities, you're bringing care to people that traditionally wouldn't, and then they miss work because they're severely sick. So it's really building some buy-in of those in the community that have the same interest of reducing healthcare expenditures but you have to pivot and present it in a way of how it directly impacts them as an organization or entity in the community you're serving. And that's going to feed into what is the operating income. So taking into account the patient revenue and payer mix, coupled with this subsidies through the ROI model. And that really gives us this number of what is the potential net income that we can have in this program. And that all funnels into the strategy and approach that you take. And so we really like to look at it from 3 approaches, with the first being that from this, you could purchase your mobile clinic. And this is likely because you have available funds, whether it be through allocated money on your budget for the next fiscal year, you've received a grant. An example is the upcoming NAP grant that might offset the cost and price of the mobile clinic. And we typically see this when people are wanting a mobile clinic to be able to do event-based programs, maybe not operating as a full-fledged satellite location. Where approach 2 is where you start to get into some more options and ways to expand and optimize your partnership with a vendor or with another organization that wants to do a joint collaboration with you. And so this is looking into leasing a mobile clinic. And there's really 2 ways that you could go with this. And you could do a dry lease where you just break the payments up over the course of 2 years, 3 years, 5 years, whatever options are available. And that's just solely for the clinic. Or you can shift into what we call a wet lease, where you could then get some staffing support. You could get some program development support. So having an operator provided with your clinic at a monthly rate. That's an option that we have found to really alleviate some of the burden on organizations that are trying to just do the work. And so we help with bringing the equipment and someone to operate it so you all can provide the care. And then our third approach is a full-fledged partnership model, and it uses a revenue share concept with it. And so this is really to alleviate that capital investment and have someone come alongside you and help build the program together. And it's a shared impact because it's equally inclined to see the program be successful. So sharing best practices and ensuring people are able to come to your program. And that leads to your optimized productivity. So utilizing your clinic like a satellite location and operating 4 to 5 days a week and being as close to the 40-hour threshold that you can be, but you have multiple sites. So you're reaching even more people that you wouldn't traditionally be getting through the front door of your brick and mortar sites. And we really like to think of this as, forget everything you heard about how it worked in the past with mobile health care. It can be scary. There's a lot of considerations to have when you build a program, and it's important to not let that sway you from doing the hard thing. But having people who have experience and can provide guidance and share lessons learned, best practices, as well as develop this financial model where you can plug your information in and determine what makes the most sense for you and your organization. That's what we're here for. We want you to be successful, and that's why we've built this model that we want to walk through with you and say, what are your numbers and what makes sense for you as an organization? And so for the last few minutes, I just wanted to touch upon program development as well. And so really looking at it as a roadmap to sustainability. And you have to start in that discovery stage where you're really trying to identify the focus of your program. You're trying to understand what are the highest needs of your populations, who do you have in your network to help support that. And then you start working into your planning phase. And you're going to develop strategies for community engagement. How do you build trust and rapport within your community? Who is there for community partners to supplement and support your program? And then you get into execution. So doing the thing, getting it launched, seeing patients, and now sustaining that. And so it does take time. It's a process, it's a journey. You're going to run into different hurdles. But we've really found that this framework that myself and two of my colleagues have built together is really helpful to ensure that you can sustain your program. And this really goes to for if you're in starting and just thinking about mobile healthcare, or if you're doing it and you're like, there's a few things that we keep running into, how can we make this better? Being able to walk alongside this foundation and have people who can be here today to answer your questions and share experiences, that's what's going to make your program that much more successful and that much more impactful. And so these are the creators behind this roadmap, that I know Maria's on this call today with me, and she comes from the school-based mobile clinic program world, and then Jackie, who comes from the addiction services behavioral health world. So that's just a really helpful tool and roadmap, and it encapsulates a lot of the stepping stones to build your program to be successful and sustainable by continuously evaluating and improving your plan for serving people. And then I'm just going to quickly go through some clinic layouts and considerations for those of you that may be pursuing a mobile clinic. So there's really all different sizes. These are examples of what you could expect, but there's essentially small, medium, and large options. But really just understanding your workflow and taking into account patient experience as well as provider experience. That's the biggest thing I always recommend is you consider the people who have to work and be seen on the clinic. So just taking time to go through your layouts with your builder and your team and get that input is really important. And then this is just an example of if you had two exam rooms, how that workflow could work, having a lab space, things like that. This is dental with operatories. So just consider how it works for you and your organization and the people physically working in this space to make sure that they're comfortable with the layout. Their input's important because you want them to be happy on their space. These are just some examples of what the inside of a mobile clinic could look like. I know a lot of you are familiar with the mobile clinic, so kind of rushing through these. And this just sums up those considerations. So thinking about where you're taking the clinic, are you in a metropolitan area where a smaller clinic is more beneficial for navigating like high density areas, what services you're going to provide, how many you want to serve. So single versus a dual exam. Do you want it to be a CDL requirement or non-CDL? So what does that look like in terms of your pool for operators to support your program, as well as the floor plan? So walking through what the floor plan looks like with your builder, understanding what it's going to give you for space and functionality for the patient, for the provider, and then workflows. How are people going to move throughout your clinic? That's really important to understand, and try to plan for in advance to make sure that you have a seamless flow to ensure efficiency of the space. And then the last piece, which Rebecca touched upon as well, was the service and maintenance of your clinic. And we really like to think of this as uptime. So by engaging in your routine service and maintenance, you're checking on it daily. You know who's responsible for the clinic maintenance and doing those daily checks and developing your cadence for service appointments. So having it planned so there's no surprise breakdowns of the clinic as much as you can avoid, and just being proactive. Having your vendors identified in advance is really important during your planning stage so that you can ensure that when the time comes for service, you're not having to then figure out who's going to do it. Some of the things that are most common to routinely do are checking your tanks, so your gray and black tanks, oil changes, both for the clinic itself, your generator, the brakes, tires. So it is a piece of equipment, it's a vehicle. So think of the things you would have done on your personal vehicle. It's the same thing with a few added pieces. And so uptime is really being able to see as many people as you can and not having the clinic out for a week at a time. And contingency planning is a big piece of that. So you want to have your contingency plans in place for if you do have service. What does that mean for providing care out in the community? And so one thing that we found helpful is to actually take time to map out who is knowledgeable in the mobile clinic space and can come to the clinics or can be serviced at their brick and mortar to provide care on the clinics in a timely manner. So we have a team who helps manage this, and this map is a snippet of some of the providers. So you can see there's some in Oregon there that are mapped, and they're really there to make sure that they're able to help with that uptime, not having a clinic down because that means patients can't be seen. And so knowing your service providers is really important and to identify them early. And then the last piece is just your operator. So having them confident in maneuvering this piece of equipment, having them understand the generator and electrical and all the things that go into these vehicles. And there's ways that you can do that. You can have them certified. This is an example of one of our certification classes that we offer. And it's really to build that confidence and knowledge for people that are doing the work. They're bringing the clinic, they're showing up with it so that care can be provided. So your operators are one of your most critical roles when you have a mobile clinic program. And so that's something that we really value and have understood. I filled the role once of being an operator for my program when we were down, and I gained a lot of appreciation for that specific role and all they do to ensure safe operations. So we always encourage, if you have the opportunity, to look for a way to get your operator trained and certified so that you can have that longevity of your program and ensure uptime. And that is all that I have for today for program sustainability considerations when you plan for your program, your service and maintenance to ensure it's functioning from an equipment perspective, as well as just having your community partners and patients and providers all involved in the conversation. It's really important to have everyone around a table to influence and build a robust, comprehensive program for you. So with that, I'll stop sharing and hand it back over to Sonia.
Thank you so much, Michaela. All right. So we've got about an hour left for discussion and sharing. Rebecca, Michaela, and I believe Maria are on the line, available for your questions if you have any follow-up questions. We've also got a couple FQHCs who have mobile health unit program experience in our virtual room. I believe I saw Debbie from the Multnomah County FQHC, Virginia Garcia, One Community Health, Valley Family. I believe you all have lots of experience. So if you have questions or if you would like to share, and really anyone from the Multnomah, oh yes, we can. I will also have a reference list going out to everyone, to all the participants following this webinar that will have all the references on it. You're welcome. So if anyone would like to share, if I could call on Multnomah County FQHC to talk a little bit about your experience in your program to kick us off.
Yeah, hi. Good morning. My name is Ryan Linsky, and I have Kendra Allen and Nan Zunkel with me today. We operate Multnomah County's mobile health program, and so I think Debbie might have had to step off for a quick second, but she might also hop on while we're talking here. So thank you so much for putting this together. Yeah, I can say we have been operating now for close to 6 months, full operations, and we have a large custom coach RV that operates with two multi-purpose exam and dental rooms. They're interchangeable between the two of them, and also with a functioning lab in the middle. And so on a day-to-day basis, we provide medical and dental cleanings, and then also point of care lab testing. And we're very close to getting behavioral health up and running, but that's still kind of in the works on our side. And we have seen kind of a mix on our side in terms of success. The demand is definitely there, almost overwhelming demand. And so that's really kind of a double-edged sword for us. And in terms of we have a lot of opportunity, but also it can be kind of overwhelming and very almost emotional at times with the types of things that we see and kind of what that does to our staff. And also, I think from our side too, really highlighting maintenance and sustainability is super important. And I think one of our biggest learnings, even now, we're still in the process and would love conversation around how to best manage the maintenance and sustainability, because we have seen downtime with just the unit itself and the vehicle itself. Trying to manage repairs can be very tricky, especially with the service providers and the vendors in the area. You're really kind of at the mercy of what their availability is. And that's been probably our biggest challenge, is trying to manage that downtime and understanding kind of backup plans and going from there. And so happy to answer any questions if folks have them. Also give it the floor to you all if you have anything you'd like to add.
I can answer the question here in the chat. Hi everyone, I'm Kendra. Like Ryan said, I'm the program supervisor for the mobile clinic. So the populations we're serving, we go out to about 10 different locations across the county. So we're going to a lot of shelters and day centers. So we're serving the houseless population. We also go to a refugee asylum seeker center, and that's one of our busiest sites by far with the highest need. We also partner with some nonprofits like El Programa Hispano Católico, so we work with Latinx families through that organization. So mostly folks that otherwise aren't accessing health services and have barriers to transportation or economic barriers, but the majority is definitely the houseless population within Monona County.
I can just add on what Ryan was saying earlier about the challenges during our downtime. Fortunately, we do have good relationships with our community partners, and they've allowed us to work inside. For example, the Behavioral Health Resource Center has a nurse triage room that they allowed us to use. We also don't have a bathroom on our unit. So that is also where it's really important to have good relationships with our partners, because our clients are using their bathroom. So during downtime, that means that we are working basically out of storage bins. So we have all of our supplies that we're carting in and out of our community partner location. So I would say that that's been the most challenging. But I would say that we're doing really good work, and the clients are really benefiting greatly from the service.
We also had a question in the chat for Rebecca and Michaela. Any guidance on administering extended relief buprenorphine, bupe, on a mobile unit?
Yes.
Okay.
No. Go for it.
Well, I'm very excited to soon have behavioral health on board. I would say it's a critical need based on the populations that we're serving. We're very close to also being able to implement MAT, and I just don't have the specific protocol or structure yet, but it's something that we're working on, and I'm really excited to start that as well.
So that's actually how I was also going to answer it as well, is MAT can 100% be done on a mobile unit. I was just working with a client last week on on putting MAT on their mobile unit. They are an organization that serves people experiencing homelessness in an urban environment, and the medical director for addiction medicine is very focused on him to do this. And one of the things that we definitely talk through is, first and foremost, definitely your protocols as to where are protocols and storage, and making sure it's secure. And I would say those are the top things that you would want to make sure that you are able to plan out in advance, in terms of when you're going to offer, who you're going to offer, how you're going to offer, and also documentation, making sure that you're tracking that, for where you're doing it and when you're doing it, how you're doing it in your EHR. It's good to all have Epic. Hopefully will make it easier. But I would say, the most important thing is, like what's already been said, your protocols, your workflows, security storage, depends on if your state rules have, specific lockbox, double lockbox rules. You want to make sure that you're abiding by your state regulations in terms of substance use management, as well as security protocols for both your staff on the van, off the van, your emergency security protocols for your patients, things like that. Just making sure you have all of that set. I would also mention and talk about what is your planning for bringing the medication onto the van, taking it off the van when you're ramping up the van and starting the day for service, and then also putting it back into, putting it back to bed and taking everything off, and where are you then storing it once your sort of bring the mobile van back for the evening.
Okay. Thank you.
Thank you. Okay, I would also love to hear from those who are outside of the Portland metro area, One Community Health or Valley Family, here on what your experience has been.
I can go. I'm Courtney Nelson. I'm the practice manager for our payout location and our mobile unit. We struggle specifically with staffing. Like, we have the mobile clinic, but it's hard when our clinics are full here to be able to have a provider and staff to go out on site with that. We use our mobile clinic mainly for support within our already existing locations. So it was just recently out supporting registration during a remodel of one of our clinics. And then we're also running a health integration program. So once a month, it's over at our outreach center, so we can have medical visits during that program. We also use it specifically for sports physicals in the summer. So there'll be about a 3-week period that we do sports physicals 5 days a week for the community, and those are free of charge. Are there other specific questions that you have specifically around our mobile unit that I could answer?
Not specifically. I just know that you guys have a mobile unit that's pretty busy. I
Yeah.
think the workforce issue is probably pretty universal.
Mhm. Yeah, it is.
Okay. And Courtney, remind everyone which health center you're from.
Valley Family Healthcare. So we're on the Idaho-Oregon border.
Thank you.
Yeah.
Hi,
Okay.
Courtney, could I ask you a quick question?
Yeah, of course.
So I'm calling you from the Columbia Gorge area. We have a mobile medical team in our large for our region, a large FQHC. So as someone else who's sort of providing care rurally, how are you staying really busy? Our biggest challenge is getting good patient involvement.
I mean, our mobile clinic is busy, I would say, but it's not as structured as like Ryan was mentioning, because we don't have set hours. When we do go out to those rural areas, a lot of it's just trying to build the partnership with the communities. We go out to an area called Jordan Valley, and that has been successful and then not successful at times. It's just like timing of the year and whether or not people are in town. And so trying to coordinate with the schools and like the Lions Club, just to let those folks know that we're coming. And then we also have like recall lists. So we're able to say, hey, we saw you last year for dental. Are you interested in seeing us again? We're going to be back on the 17th. So just trying to do outreach prior to going has been successful for us.
I just want to piggyback on what you're saying there, Courtney, because that's true, is taking the time before you deploy to build those relationships with the community partners and have them help get the word out is really beneficial to your program because they're already trusted in the community with those people. And so they can actually help drive patients to the clinic because they see from the community member perspective, they see that that person at the organization trusts you to provide care. And so it starts to bring more people to your program and then building your cadence and some routine so that then you can start building that revolving patient volume. So people actually following up on their care and coming back and tracking people that you've seen is another great tool that you're doing of who did we see last year and who might be due now this year for another routine cleaning or whatever it may be. Starting to build those connections and lean into your community champions will really help yield some of that success of patient volume and maintenance.
Ryan and then Mitty.
Yeah, I was just gonna add that exact same thing, Michaela. That was fantastic. We've put in a ton of effort towards building community partnerships, and I think it has paid off, and it has been a lot easier for us to build trust. And so, yeah, focusing on those community partnerships, super, super important.
Mitty, go ahead.
So in Michaela's slide, she posted it over like a 3-year plan. You would have I don't know what the provider efficiency rates of visits going from like 60 to 95%. Courtney, what kind of provider utilization rates are you seeing?
Oh, I don't know if I'd be able to answer that specifically right now. Specifically, like when we go out, how full of our provider schedules, is that what you're asking?
Sure, something like that.
I would say we have a lot more success with dental than we do with medical, specifically in the rural areas. So I would say for the dental side, when we went out a couple months ago, it was probably 85%. And of those patients, only one no-showed. So we probably had 7 scheduled for the day, and we completed 6 of those visits.
Thank you, Courtney. Maria.
Yeah, I just wanted to add, this is a great question about how do you go to these rural areas and how do you become successful in the rural areas? I think what you have to do also, just to add to what Michaela was saying, is you have to treat each rural area as separate, right? So there's a different landscape in each one of them. This is very regional. So get to know whatever works when one rural area cannot work in the other rural area. But then also your question about the percentages, that's exactly what you have to do. Do a reality check on each of those and say, how many times do I go to this rural area and what community sites can I reach out to kind of think about the gaps on that area specifically. So be very specific into your, reaching out. I think it would be a good way. When I was in Miami, we had the farmers. So the way we could go and reach out to the farm workers population that were rural, were going with their schedules, getting to know what their schedules were, right? We couldn't go when it was convenience for us. It was more of do an evening, do a Saturday afternoon, do a Sunday, whichever would work best. And I know with some of the programs that would be harder, especially with providers, but it's just looking at that and then also kind of building a telehealth kind of consult after. So your first consults can go just regular, and then you build like telehealth, you educate the community on how to do telehealth and, keep going, keep seeing them like that. So that's just what I wanted to add.
Thank you, Maria. And again, Maria is from Mission Mobile Medical. Jennifer, I see you have your hand up.
Yeah, I'm from Valley Family Health as well. I'm the director of operations and I support Courtney. Something that we do with the marketing for our mobile unit is we send mailers out to those rural areas and make sure that they hit the mailboxes or the post office boxes to let that community know that that mobile unit's coming. So like in Jordan Valley, we'll make sure that we target those mailboxes. And I think it's really important that that happens because in Courtney's case, we've had people call and say, hey, we just want to make sure you're coming and that mobile unit's going to be on site. So I think that that's another tool that we use to get the word out is the flyers and those mailers. And I know mailing can be expensive, but it can be also really effective tool. So if you target some of those areas with mailers, I think that we found it to be a real effective tool, especially out in those rural areas, because social media, I know people use it a lot, but out in rural areas, you'll find that people don't have access to that and they don't use it as much. And so, especially in the farming communities and people where they don't have access to internet as much, they'll go and they'll use their mailbox and they'll use those tools a little bit more and they'll save those and they'll put them out and they'll wait for the mobile unit to arrive. So just wanting to give that feedback. So.
Thank you, Jennifer. Holly in the chat also said reaching out to your local EMS providers is also a good idea. They're seeing the high utilizers who are probably not connected to a PCP and they might know pockets where care is needed. Ryan and then Michaela.
Yeah, I was just gonna say that our model is a walk-in model. We don't make appointments ahead of time, and that's really been successful for us in order to fill the schedule and stay busy because there could be high no-show rates and people are very transient. So we're not planning on them being at the same location every week. And so we pull up and we just take first come, first serve. And our provider Nan is really great too about just connecting with folks and making sure that they do return for their follow-up. And I feel like we've been pretty successful with our follow-up rates, higher than I thought we would be. So that's just how it works for us, is not making appointments ahead of time and just taking walk-ups.
Go ahead, Michaela.
Yeah, so there's a lot of great discussion happening with community engagement and continuum of care for these patients and really understanding the population that you're trying to serve is the most important thing to have a good kind of understanding and landscape of. One thing with some of our clients that we've worked with is a rapid community needs assessment that's tailored to a mobile clinic program to understand what's the best way that they prefer to be communicated with, is what's the time of day that they want to see services, because what you'll find is some of these people are working, like you have migrant farm workers who work, they might start work at 4 a.m., but then be done for a few hours in the middle of the day and then have to be back to work in the evening. Or they work 12-hour days. So taking the time to give them a voice in the way that you plan your program can be helpful and yield some greater success too. So letting them be involved in that and key informant interviews is a great way to do that, just spending time in their community. And that can be without having the clinic there. So one thing that I found helpful when I was leading my mobile clinic program for the county was actually attending different community events that they had. So faith-based organizations, attending a service or a family event, and just being there to answer their questions and asking like what they were seeking for services, where they were just experiencing some challenges accessing care. And I was just giving them a space to be able to talk openly and tell me what they were facing. So sometimes it takes a lot of work. It's intentional, but it can really make a difference in your program and the way you deploy and implement it. So I'm just throwing that out there too, as sometimes it helps to just take a little extra time to capture that data from the people you're trying to serve. And then the last thing I'll say, because I see a bunch of hands up, when you're doing marketing and communications and outreach, one thing we learned was specifically in our Latino community was they communicated mostly through the WhatsApp platform, not social media. So while we were doing bilingual posts on Facebook, Instagram, our website, the way that we got the most results and interaction from them was utilizing their communication platform, which was WhatsApp, because they can communicate to another country with their family who was there. And so that was a huge breakthrough for us to be like, why didn't we think of this sooner? But we actually gave them the space to tell us what worked for them. So it can really yield some great results for you in your program and have that breakthrough moment if you just give them the space to share with you what works best for them.
Danielle.
Thank you. This is Daniel at Virginia Garcia. We are starting to expand our mobile health program, and I have a question related to scope of services. For example, we may not be able to do a root canal in the mobile clinic, or there may be some medical procedure that we can't provide because either the equipment is not available or the van is not the most appropriate environment to do that. How do you work with your partners in terms of working with patients for referrals? And I'm specifically asking for examples where the program is purely mobile and you don't have a brick and mortar clinic to where the patient can be referred within your organization. And also, what if your organization has a brick and mortar clinic, but is having access limitations, be it because of FTE challenges or simply the access is very limited? Do you build the program around anticipating that you need to build some access for these referrals from the mobile program into the brick and mortar clinic?
I think you've stumped everyone, Daniel.
Sorry about that.
I can kind of chime in. I can say this question doesn't quite fall with us because we do have brick and mortar sites that we very actively refer patients to that are more complex, that need like basically root canals or more specific dental procedures or more like thorough medical procedures as well. But I will say we have tried to work with outside specialty clinics as well to do a lot of like the more complex referrals. And so we have a referral coordinator that has multi-functions, but does a lot of calls and coordinations with these specialty folks and works with all the different OHPs and stuff like that for getting folks kind of transferred over to there, because it is also an issue for us too with access and things like that. And so it is an excellent question and a tricky one to definitely answer.
If I can add to that, I would say the majority of the referrals that I place are external and not within the Multnomah County clinics. I do advise that they establish with one of our brick and mortar clinics just to receive more comprehensive wraparound care. But I would say the majority of the referrals that I place are from me directly to cardiology or dermatology. So I rely heavily on Connor, our referral coordinator, for that.
Thank you.
And Daniel, I'll take a stab at this as well. I was also going to comment on the previous questions there earlier. On our mobile health center, coming out of COVID, our brick and mortar clinics, dental clinics were really hit hard staffing wise. And so, yes, we struggled with that on that side, as well as in trying to get referrals to outside. But what we have on our mobile is a team that includes a community health worker, and really everyone on our team are community health workers. And so really utilizing them to address those SDOHs, to work with community partners, to work with referrals, to work with our dental teams. We also sat down with our brick and mortar clinics and said, hey, how do we meet these serious needs? What systems do you already have in place for these urgent or emergent dental scenarios? And how can we streamline that process for our team? And just partnering in those ways, as well as being able to really address those SDOH issues and communication for our patients who don't have phones, can't receive a call back from a referral for surgical needs and things like that. And so we would sit down as soon as we sent in the referral, our CHWs and teams would call the referrals clinic that we were referring to and just set up the appointment right there on the spot on the phone with the patient, and then create a plan to make sure that we can connect with them, get them to their clinic or to their appointment on the day of, so that there just weren't any excuses for no shows or anything like that. So
Thank you, Robert.
and then around CHWs also addresses the question around how to build capacity. And now we're down here, I'm with La Clinica in Jackson County, and we're not metro and we're not quite as rural. We certainly have rural areas. But what we found works, and our clinic, when we were going out, we actually lost it to a fire in the last year, and are looking to get a new one. But what we found worked for us was working with our community partners and sending out our CHWs and behavioral health support specialists into the field beforehand and developing relationships, not just with our community partners, but with the people around there face to face. Building trust and doing that regularly was really vital to our success. Also looking at community partners that have events. I mean, even when you become far more rural, they're fewer and farther between, but there are usually things like food banks that you can partner with. Any sort of events of outreach that bring people in, partner with them, start going in advance, and develop a consistent schedule with those events. And just the consistency of being there builds capacity. And so we'll when we're trying out a new community partner, we'll go for for a month, maybe 6 weeks, to see how that consistency builds up, and capacity builds. And if it's not working, we try a few different things along the way. And if it still doesn't work, then we have to cut it off at that point. And we've also noticed a lot of patterns around time of the month. So particularly with food banks and things like that, first week of the month, there's almost no one there. So if you're looking to capitalize on those things, then, families have just received their food card, their food money. They're not needing those resources as much. And so going in the last 2 weeks of the month, targeting those for clinics that aren't out every day, all week, is maybe a good strategy as well.
Go ahead, Rebecca.
Great, thank you. I wanted to follow up and piggyback on what Robert was saying, and also address the trauma-informed care and safety planning that Michelle posed. Is the thing that I really wanted to highlight about what Robert was saying is the integration of the mobile unit with the rest of the FQHC support services. And you want to think about your mobile unit as not a siloed entity. It is part of your FQHC, and you want to think about building and work and planning your workflows and your policies and procedures and your staffing model as a key component of your entire FQHC. And so when you are planning your mobile program, when your van is going out, whether you take it out seasonally, you're starting a mobile program, sitting down and talking to everyone at the table who needs to be involved in terms of what is working on the van and what is working off the van, and thinking about those operational support services in terms of your enrollers, your referrals, your referral specialist, as well as thinking about what kind of how you're going to use EHR and what kind of special documentation is the mobile team going to make in EHR, and what does that look like for the rest of the clinical team and the brick and mortars when hopefully that patient, again, you want to make sure you're doing that continuation of care. And if you're bringing that patient back into care in the clinical in your brick and mortar sites, to get additional support services like Daniel was saying, whether maybe they need something additional, thinking about bringing all of that planning together. And when you are thinking about planning your staffing for your mobile unit, is what are the policies and procedures in terms of skill set and performance expectations you have for all of your staff, and then how does that translate to the mobile van? So maybe it's maybe you look at like your performance expectations for all of your staff, and there's additional aspect for your mobile team, and thinking about what are that skill set. And so to answer Michelle's question is that pretty much when I was running my mobile team, everyone got all of the same trainings. And so everyone was trained on trauma-informed care and safety planning. And then the mobile team got an additional safety and security and emergency training specifically for the mobile units.
Thank you. I see Daniel, Robert, and Michaela.
Thank you. So this is a quick follow-up question, or rather a different question on financial sustainability. For Virginia Garcia, we are very close to other community health centers, and also there is the new APM methodology and capitation. How do you work that out with your partners in terms of other organizations and the CCOs when you run into patients who have not received care, they're not established, but they are assigned to a different community health center and they are requesting services in your van? And this has to do with reimbursement. Thank you.
Again, asking the hard questions, Danielle.
I'm going to jump in here. I know a little bit about Virginia Garcia, Daniel. I had a great call with Angie last week, and so I'm fully aware of the barriers that you're having around the fact that you have capitation, but yet you have this, you have a, you're building a robust mobile program. Is because I think I particularly think that you're in a particular interesting, unique environment. I would have a conversation with your ACOs and your managed care plans. I think Care Oregon's your biggest one, about how can you serve your mobile programs specifically and to the best of their abilities of those patients with the fact that you have that capitation. And is there some way that you can work with them, and maybe there's a carve out? Maybe there is an aspect where you, even though they are assigned to a different provider, that because you're going to see them, you're not going to turn them away. Is there some ability where you can still maximize and capitalize on some sort of payment for that patient, for that service you provided on the mobile van? Because mobile vans don't fit. People are transient. Mobile vans are transient. Like, it's, I understand the theory of capitation, but also, mobile vans in transient populations, like people experiencing homelessness and a migrant population, don't fit neatly into that financial plan that was set out by an ACO.
And I also wonder, is this a metro area focused experience, or are there other health centers across the state who are in areas with multiple CCOs who are also having this issue? Robert, go ahead.
I was going to speak to the trainings thing, and so if someone has an answer to that question, I'd like for them to be able to answer before I jump in.
Or conversely, are there other metro area health centers who also have run into this issue? Okay, so Mitty says they're having the very beginnings of this issue because they also serve Oregon and Washington, or are Valley Family. Do you run into this issue with Oregon and Idaho? Okay, Robert, go ahead and ask your question about the trainings, the tablets.
Well, the tablets is my own question. Let's throw out there. So as far as training, so our entire organization does trauma-informed training for all of our brick and mortar clinics, our school-based health center clinics, our mobile clinic, and everything. But we do recognize the populations with which the mobile works are more extreme in some ways, and that there is a lot more trauma, more mental health concerns. And so we do focus training on those things. We require everyone to go for our main team to become a community health worker, no matter what their position is, except for the providers. We we have brought in a detective who is an Alice trainer to look at our mobile unit and come and provide training to our team around what to do in different scenarios, and based on our community partner locations, the best actions to take. De-escalation trainings. We also try to get everyone trained in ASSIST, which is a 2-day long suicide training. And we do special training and follow up with around vicarious trauma. And right now we're actually looking at our current systems for support, individual one-on-one staff support when we or they are seeing signs of vicarious trauma, for debriefing and working through that.
Robert, if you could send me a link to the Alice training and the ASSIST training, that would be great. Okay. Oh, go ahead.
Yeah, I mean, well, yeah, sure.
Michaela.
Yeah, so Robert, that you were taking the words right from my mouth. That's exactly what we did with my program, is brought someone in who could walk us through the mobile clinic in different scenarios and share with us ways to position ourselves with the patient, how to handle different scenarios. Another resource that you can utilize too is your local police department. So they can come do trainings, especially if you understand who you're going to be serving in different communities that may have various complexities that you could encounter. So knowing who those people are and even having an emergency contact list that's posted in your clinic, and it has all the local police departments, fire department people, so that they know your schedule, and that adds an extra layer of security and safety for your staff, because you want your staff to feel safe on the clinic and feel confident in the care, but know that they're not alone. And so we worked in one area that had a higher rate of crime and violence, and there was a known kind of history there. And so we actually asked the local police station to just every hour just do a drive-by to make sure we were doing well, just pop in, see how things were doing, because we knew, but we did it in a way where they weren't coming onto the clinic to deter people from it, but more so for our staff to feel like someone had their back, was watching them, making sure we were able to safely provide care, but without compromising the trust that that community has towards the law enforcement. So that's another way to lean into the emergency response people that you have around you to help train and provide resources that they may have. So those are all great, and everything Robert said and Rebecca shared are really important in the mobile healthcare space.
Thank you, Michaela. I do want to ask if others are using tablets for utilization, and what the process looks like, and if you're using an app or another message to communicate with Epic.
So I can try and answer a little bit of that. I used to work for the University of Miami, and we used to have the mobile clinics and those programs. So one of the apps we used specifically for the rural communities was Cognito Forms. So we created a form that could get the information to the patients. It's HIPAA compliant. And then our IT department communicated that with Epic. And then from there, patients could get messages a little bit easier since they had entered the information on Cognito form. So that was one of them that you can look into. Most of the work was done by the IT department over at the university, so I'm not sure exactly how they connected, but I know everything was connected and it was a little bit easier because it was through forms rather than us just entering the information. We would give them tablets, they would enter the information, answer like social determinants of health questions, and then just this was the way we thought that would work well. We did it through a QR code too. They could do it through their phone, fill out a survey, fill out everything, and then select different date of appointment. And then we had patient navigators who would get in touch with the patient. So that was one of the ways we did that. So.
Thank you. Ryan, go ahead.
Sorry, I don't have an answer to this since we're using paper registration forms currently, but just have another question if we have time for it.
Yes. Go ahead.
Awesome, thanks. So wondering kind of more on a maybe not necessarily clinical basis, but what folks are doing in terms of infection control precautions in response, and how you manage like sterilizing instruments if you use them for any kind of procedures on either on the dental side or on the medical side, and then also what your process is in terms of managing like clean water and like HVAC type facilities, and if you're doing any kind of thorough inspections and maintenance on that type of stuff to like have a routine for that. It's been something that we've been trying to work through and don't quite have a firm process nailed down quite yet.
So I can jump in on some of that. One thing that was really successful with our program is actually bridging the sterilization processes that we used in our brick and mortar. There's also mobile equipment you can put onto your mobile unit for sterilization of instruments, dental especially. So there's some options of looking into that. But in terms of like doing a deep clean of your clinic, or if you have a potential communicable disease exposure that's highly contagious, having that in place ahead of deployment with whoever you use internally at your site to be able to come on, have it written into the contract is the quickest way to get it done. Just to make sure, but following your typical protocols that you would in your brick and mortar, because it's no different of if it's on the clinic or in-house for transmitting the virus or whatever's going on. With the HVAC side of things, so are you referencing like your gray and black tanks on the clinic and like water and things like that?
Yeah, so the plumbing
Unit.
system with the water and the gray water, black water tanks, but then also we have like air conditioner units, and didn't know with like standing water if that introduces like Legionella and stuff like that that we also need to be conscious about.
Yeah, so great questions on that. So the AC units, especially ones that sit on the top of your mobile unit, there's the seal around it. So that's the biggest thing, is to make sure that the seal, and it's like a little gasket that's kind of gets compressed and it's meant to be crushed a little bit. It's a style they use. So as long as there's no damage to that, it's making sure that that just is always in good health. There's filters in your AC units as well that you can change internally. So maintaining that and getting into a good cadence of that. And then with your gray tanks, there's also, you don't want water to sit. One, it gets smelly. No one wants to smell that on the small space. But if you know you're not going to use the clinic for some time, make sure that you empty your tanks fully. And that's also when you have just fresh water in there, not even the gray tank, just trying to empty that so it doesn't sit and develop that kind of stale film. And then there's little tablets. You can get like RV level tablets that you can put in there to help with the smell and keeping things from bacteria and stuff from growing. So there's different ways, and we can always talk through it more. Like we have a whole service team that they talk all day long about these different things. and can speak to it further depth than I can. But that was what I experienced when we had with our clinic.
Rebecca and then Robert. Oh, Rebecca, you're still on mute.
Just saw that. I was going to say thank you, Michaela, for going first because I was really hoping Mission would have such the vast information that you did just provide. I was also going to share my experience because we ran our mobile units during COVID, and so we had an entire sanitation sterilization protocol, more not for equipment, not for like utensils or things like that, more for space and people. Again, replicating the gowning and protocols that we did for our staff and all masking, but we also contracted with a vendor, and this became part of the regular maintenance and cleaning for the van, was that we had a sterilization vendor that would come in and clean the van. I want to think weekly, but I can't remember. But again, as Michaela said, like you set that up early and set that schedule for that vendor to come on and clean that van. We also got air purifiers, and specifically the light cleaning air purifiers, like that. I think it was like a blue light, is what the CMO we put on the van as well. And then for it, especially for, as Michaela was saying, for those air conditioners that sit on top. And if you have concerns about Legionnaires, and I am from New York City, and we have a lot of, sure, I don't know if you've all followed the news, but in New York City, there's been a lot of public health news around Legionnaires. I would just say, just make sure you do testing on a regular basis of those units and of those water tanks, to make sure that you're just getting ahead of the issue in case that, and just to be aware of it. And if you do, hopefully you won't have it. But just to set up, again, that planning and that cadence of as well. Yeah, those are my ideas.
Thank you, Robert.
You both did an amazing job, Michaela and Rebecca, in covering pretty much all the different things I was going to say. In terms of the cleaning utensils, they do have an autoclave that's about this big. We had one on our mobile that we don't have anymore. That we use to sanitize all of our dental equipment. We had contracts with Patterson to come out and service it regularly as part of the maintenance schedule for it. And then as far as testing the water, we would do that every week. We would take that in and test it at a local facility just to make sure everything's copacetic. And with tanks, because we go out weekly, we just drain them every week at the same time because empty and refill the main tank as well, just to make sure that everything is up and running and ready. We never knew if we were going to have a super heavy day and run all of the water out or not within just a few days. So we just kept it standard.
Excellent. Other questions or information you'd like to share with your colleagues? You've heard from Virginia Garcia, One Community Health, anyone else who runs a van or a mobile health program who would like to comment? Thank you, Robert. For ALICE training, we reached out to locally certified trainer who came and did an evaluation and training specific to our needs. It was local. And ASSIST is an in-person training. We'll keep an eye out on Eventbrite through our local mental health department. Okay. I will see if I can find some resources across the state to send out around those when I send out the resource list. Anyone else in the Portland area, Cascadia, or who else do we have on the line? You want to talk a little bit about your van programs? Okay. Well, we are right at 10:59. I am going to put information on the evaluation in the chat. If you all could once again go to menti.com and put the code of 7993 7012 in, and go ahead and start that evaluation. I'm also going to put it up here on the screen in just a moment here. Let's see if I can hit all the right buttons. There we go. And just take a moment to fill out the evaluation. The QR code is up there. We very much appreciate hearing from everyone and learning what was valuable and how you would like to connect with your colleagues. I appreciate the time. I want to thank Rebecca, Michaela, Maria, our guests who were on the phone for coming and sharing their experience and having and their questions as well. And as always, you can email me and let me know if you have other questions.
Thank you for having us today. This is just Michaela from Mission Mobile.
Thank you.
I just want to say thank you. And, as you all are going through the mobile healthcare journey, we're here to answer questions. We want to see you be successful. And so there's no silly question. We've all been there. We've lived that role of boots on the ground, and we just want to help. So we always just are an open door and here to answer questions that you have. So I hope you all have a great rest of your morning. And it was fantastic co-presenting with you, Rebecca. Thank you for sharing the space.
Thank you, Michaela. You jumped on the unmute so quickly. I was going to say thank you to Oregon PCA. Thank you to Mission Mobile Medical. It was such a joy to present to all of you today. And I also offer up the whole, if anyone has questions about content that I presented, mobile, maps, mobile law, any of those, please reach out. And I know Sonia will share the slides and my information as well. So I hope to hear from all of you. And Sonia, again, thank you to the OPCA for this opportunity.
Yes, absolutely. All right. I will also be sending out another link to the evaluation if you miss it today. And as always, I appreciate everyone's time. Thank you for joining us and have a happy Monday.